Hi friends, welcome to the Emergency Medicine channel. Myself Dr. Ashik Envy, doing post-graduation in Emergency Medicine. In this video, we are going to discuss about the treatment part of bradyarrhythmias and tachyarrhythmias. Before moving on to the treatment part, we have to define what is unstable tachy and unstable brady. It is common for both bradycardia and tachycardia. It will make certain conditions which make them unstable. Okay, so what are the signs of instability? Signs of instability. It is common to both tachy and bradycardia. So the first sign is hypotension. Whether the bradycardia or tachycardia causing hypotension in a patient make it an unstable brady or unstable tachy. Second one is acute altered mental status. Okay, chronic altered mental status is not accounted for the instability of the presenting brady or tachy. It should be acute because of the hypoperfusion of brain due to bradyarrhythmia or tachyarrhythmia. So that is the second sign of instability. The third one is signs of shock. Patient presented with shock due to this arrhythmia. The fourth one is ischemic chest pain. And the fifth one is acute heart failure. So these 5 things are the signs of instability. Okay, now we are moving on to the treatment part of bradycardia. Treatment of brady. Usually the bradycardia is defined as bradycardia is heart rate less than 60. Heart rate is less than 60 beat per minute. But typically when the patient presented with symptomatic bradycardia, the heart rate will be less than 50. For usually heart rate will be less than 50 can cause symptoms of bradycardia. So bradyarrhythmia is defined as heart rate less than 50. Okay, it can produce symptoms of bradycardia. So whenever a patient with bradyarrhythmia present to our emergency department, first we have to do our primary survey. Okay, so in the primary survey, our ABCD assessment, first part is airway. So you should maintain a patent airway. First thing is always airway. So maintain a patent airway. Then move on to the breathing part. In the breathing part, you have to give O2 if patient is hypoxic. Give O2. In the circulation part, you have to put an IV line, IV axis, and connect the patient to cardiac monitor. It will show heart rate, BP, saturation, etc. Then in the cardiac circulation part only, if the time permit, take a 12-lead ECG. But don't compromise the treatment for waiting 12-lead ECG. If time permit, take a 12-lead ECG. Okay. Now, after your ABC assessment, for the D and E part, take a proper history and examination. This also if time permits. Okay. After your primary survey, you have to look for signs of instability, which we have already discussed. Look for the 5 signs of instability. If there is no signs of instability, nothing to do with the patient other than monitoring. So our treatment goes to monitoring. Monitor the patient whether he is developing any new signs of instability. But if already the patient have any of the 5 signs of instability, yes, he is having signs of instability, then go for the drug called atropine injection. Atropine. We will discuss the dose of atropine in the later part. But if the bradyarrhythmia is not subsided with the atropine, with the maximum dose of atropine, then we can go for either transcutaneous pacing or injection dopamine infusion or injection epinephrine infusion. These are the next treatment options. Still, even after giving these medications, if the bradyarrhythmia persists, then the last treatment option is expert consultation. That is a consultation with a cardiologist. Consultation and transvenous pacing. This is the treatment algorithm for bradyarrhythmia. Now, how to give atropine? Atropine is the first drug in the bradyarrhythmia. So the dose of atropine, first dose is 1 mg bolus through the IV line, and you can repeat in every 3 to 5 minutes up to a maximum dose of 3 mg. So you can give maximum 3 doses. Okay, this is how you give atropine. The next drug is dopamine. If the bradyarrhythmia persists even after giving atropine, you can consider either dopamine or epinephrine or transcutaneous pacing. The dose of dopamine is 5 to 20 mcg per kg per minute. And the next drug is epinephrine. Here the dose is 2 to 10 mcg per minute. It is not per kg, it is mcg per minute infusion. We have already discussed about the causes of bradycardia in the previous videos. So this is how you have to manage a patient with bradyarrhythmia. Okay, first look at the heart rate. If it is less than 50, you have to do a thorough primary survey. After primary survey, you have to look for the signs of instability, which I have already discussed. Then if there is no signs of instability, you have to monitor the patient. If there is signs of instability, the first drug is injection atropine. Not subsided, then you can go for transcutaneous pacing or injection dopamine or injection epinephrine according to the recommended dose. Still, if it is persisting, you can get an expert consultation from a cardiologist and take the patient to cath lab for transvenous pacing. Okay, that's all about bradyarrhythmia. Now, let's discuss about tachyarrhythmias. Tachyarrhythmia also, treatment of tachy. As discussed in the bradycardia, tachycardia is defined as heart rate more than 100 beats per minute. But here also, when the patient presented with a symptomatic tachycardia, typically the heart rate will be more than 150. So the tachyarrhythmia is defined as heart rate more than 150. Okay, so here also you have to do a primary survey. In the airway part, you have to maintain a patent airway. B part, again you have to give O2 if hypoxic. Look for the saturation. In the C part, connect to get an IV line, IV axis, and connect to cardiac monitor. And get a 12 lead ECG and do the D and E part with history and examination if time permits. Okay, after the primary survey, look for signs of instability. If there is no signs of instability, then you have to check the QRS complex, whether it is narrow or broad. Okay, QRS complex wide or not. A wide QRS complex is defined as QRS more than 120 milliseconds. Okay, if it is not widened, no, that is it is narrow. Then the rhythm will be SVT or atrial fibrillation or atrial flutter. Okay, it is a narrow tachyarrhythmia. Okay, so you have to consider it is, but the patient is stable. There is no signs of instability. Okay, patient is stable, but the QRS is narrow. So the first step, if it is a regular narrow tachycardia, if it is regular, okay, regular only, the first step is vagal maneuver because the rhythm is SVT. That is why you have to perform the vagal maneuver if it is regular. Again, if it is not aborted by vagal maneuver, then you have to give injection adenosine. It is also done if it is a regular rhythm. And what if it is an irregular rhythm? You can consider beta blocker or calcium channel blocker, and you can take a expert consultation, that is our cardiologist. So this is how you manage a stable patient with narrow QRS complex tachyarrhythmia. If it is a regular, that is SVT, you can do vagal maneuver or injection adenosine. If it is irregular, you can give beta blocker or calcium channel blocker and take a expert consultation in all cases of narrow tachy. What if it is not narrow, it is wide? Okay, it is, yes, it is wide QRS. Okay, wide QRS. So you can give here also, you can give injection adenosine, but only if it is regular and monomorphic, because the one of the DD of regular monomorphic wide complex tachycardia is SVT with aberrancy. So we can try injection adenosine. If it is aborting with the injection adenosine, it may be SVT with aberrancy. Okay, otherwise it will be monomorphic ventricular tachycardia. Okay, so if it is not terminating with injection adenosine, we can give antiarrhythmic, other antiarrhythmic, which we will discuss in later part. Okay, antiarrhythmic infusion can be done and take expert consultation. Okay, but if there is signs of instability, yes, the patient is unstable, then nothing but go for synchronized cardioversion. Okay, in both these cases, if there is refractory, in all these cases, if it is a narrow stable or wide stable, or the patient is unstable, if there is refractory tachyarrhythmia, you can increase the energy level of cardioversion. You can you can do addition of antiarrhythmic and take expert consultation. Okay, so now about what are the antiarrhythmic used and how to do synchronized cardioversion. So first about adenosine antiarrhythmic. First drug is adenosine. The adenosine first dose is 6 mg IV bolus. Usually it is given through the cubital vein. After giving the 6 mg of IV adenosine, you have to give a saline push and then immediately elevate the limb. Okay, and if it is not terminated, a second dose can be given. And it is 12 mg IV. Okay, this is how to give adenosine, and it is a drug of choice for SVT. Okay, so it is given in narrow regular tachy and also wide regular monomorphic tachy, because it is a one of the DD of monomorphic regular wide tachy is SVT with aberrancy. Okay, so about the second drug or the drug of choice for wide complex tachycardia is procainamide. Okay, the dose is 20 to 50 mg per minute. Okay, you can give a maximum dose of 17 mg per kg. Okay, and the maintenance infusion usually done at 1 to 4 mg per minute. Okay, and the contraindication, the drug should be avoided if there is prolonged QT interval or congestive heart failure. Okay, the dose is 20 to 50 mg per minute. You can give until antiarrhythmia get suppressed. A maximum cumulative dose is 17 mg per kg. A maintenance infusion is given at a rate of 1 to 4 mg per minute, and the contraindication is prolonged QT interval and congestive heart failure. And the other drug used as antiarrhythmic is amiodarone. And the first dose is 150 mg over 10 minutes. It is given over 10 minutes. Okay, and for if the rhythm got terminated, you can give a maintenance dose at a rate of 1 mg per minute for 6 hours. Okay, and the fourth AHA recommended drug for tachyarrhythmia is sotalol, and the dose is 100 mg over 5 minutes. It also contraindicated in case of QT prolongation. Okay, this is about the drugs that we will give in case of a stable tachyarrhythmia. But for unstable tachyarrhythmia, the only indicated treatment option is synchronized cardioversion. So synchronized cardioversion. So before giving synchronized cardioversion, you have to take a consent. You have to sedate the patient, and the crash cart should be ready. Okay, these three things are very important before giving synchronized cardioversion. Take consent, sedate the patient properly, and get ready with our crash cart. Okay, after taking these three, then we will proceed to synchronized cardioversion. Previously, in 2015, the AHA recommended joules for giving synchronized cardioversions are as follows. For regular narrow tachy, that is our SVT or atrial flutter. The recommended dose is 50 to 100 joules. For irregular narrow tachy, it is atrial fibrillation, 120 to 200 joules. And for wide or monomorphic VT, the recommended joule is 100 joules. Okay, that is the joules for synchronized cardioversion recommended in 2015. But according to 2020 ACLS guidelines, it is according to device recommendation energy level. Okay, so device recommended energy level. In 2020 modification, there is no specific joules according to the rhythms. It is according to recommended device energy level. Okay, this is how you treat a patient with a unstable tachyarrhythmia. Okay, I think the class is useful for you, and you can do subscription of my channel if you are interested in emergency medicine videos, related videos. Okay, thank you.